in this collaborative about substance use disorder, about depression and anxiety. And of course, it's really important to talk about trauma because most people come to a substance use disorder, having experienced some trauma at some point in their life. And of course, even for people who don't have substance use disorders or don't have depression and anxiety, trauma is something that affects so many patients and people in general, and that will show up in your offices, in your clinics, in your L&D units, and trauma can really manifest itself in so many ways that are really important to patient care, regardless of whether someone has a substance use disorder or not. So I'm very excited to introduce Dr. Helen L. Coons, who is going to be presenting to us today on trauma-informed care in the L&D unit, and really talking about how we can bring a trauma-aware lens to all of our patient interactions. So Dr. Coons, feel free to share your screen and we can get started.
Wonderful. Well, thank you so much for sponsoring this important conversation and series, and for the invitation to work with all of you. I'm going to go on and off sharing, and as much when I go off, if many of you could come on video, that would be great. It's just a much better experience. It's really, I must say, in the last 6 months, I've been asked to speak about trauma-informed care in women's primary care, OB, and now L&D and pelvic pain and other settings multiple times. And I'm very pleased to see the increased interest in this vital topic that's deeply, deeply affects women's well-being and consequently family well-being. I want to just point out for a moment that I have no relevant financial or commercial interest to disclose related to this presentation. So I'd like to know a little bit about you. So let's see, I'm going to just bring stop sharing again. And could you possibly come on screen? I know some of you might be eating lunch, but could you tell me how many of you are OBs or nurse midwives, and just put your hands up or say yo or do something? A couple of hands. Nice to see some familiar faces as well, and hands. Okay. How many, hi Sarah, how many of you are L&D nurses? Couple of you, excellent. How about social workers? I know a few of you. Great. And how about behavioral health providers? Okay, and I see we have some head nurses of L&D. Any administrators from L&D settings? Hard to tell. Okay, who have I missed? How about substance abuse counselors? All right, well, that just helps me to tailor a bit more. Thank you so much. So why is that great? All right. That did not like that. That might not have been a good idea to do. Okay, let's talk about our patient case, and we're going to, towards the end of this afternoon, we're going to spend some time as a group speaking about how we might navigate her trauma-informed care. Ms. R is a 23-year-old single female who was admitted to labor and delivery for her first baby. During the first clinical encounter with you, she became highly agitated and tearful when you started to examine her with marked shortness of breath and physical bracing. She had just completed a residential treatment program about 10 months before her admission for her delivery. She's being induced. Ms. R was gang raped by male strangers at age 19 on her way home from a friend's house one evening. Obviously, this case and all these photos are not actual patient care. So give me a second, I'm having trouble. There we go. So whether you're in an OB office in the outpatient setting or on labor and delivery, we all work with women who experience a broad range of types of trauma. And I like to go through this not in detail, but more to just do a heads up of trauma in its broad definition. I know that you as a group are very focused on substance use per se, and we'll talk about that in a minute. But I want to broaden the concept of trauma and how the range of traumatic experiences that women might come to either currently or in their past or both. So certainly childhood physical abuse and sexual abuse, childhood rape, also sexual coercion, adult sexual assault and rape, interpersonal violence. Physical assaults have increased, especially during COVID, and especially to women of color, especially in marginalized communities. We've seen increased rates of criminal victimization. You see a subset of women who have had medical trauma, maybe from a prior delivery, and actually I'm working with a woman right now, but also other types of medical trauma. Certainly, we see a very long list of women who have experienced racially based trauma and hate crimes. A subset of your women will have experienced institutional sexual and physical trauma, combat and military sexual trauma. If you work with women from immigrant and refugee communities, you may also experience women who treat women who have experienced female genital mutilation or cutting. Sadly, also in our immigrant and refugee population, we see a number of women with political, state, or war violence, or as primary victims or as bystanders. And trafficking is not spelled right, human trafficking. So I'm not going to go through each of those today, but I like to do that slide to help everyone think about trauma broadly and across the lifespan for women that you see on L&D. I'm not going to do a lot of epidemiology, but just as a kind of to ground smooth the playing field, roughly 30% of women have experienced sexual trauma in their lifetime, roughly 20% interpersonal violence. I think you'll agree that, again, we see women across who have experienced trauma across classes, racial and ethnic groups, age, across women with varied sexual identities and partner status. So many of you on this call work with populations at risk. So adolescents who are delivering, anybody with a prior history of an adverse childhood event, certainly that are women from marginalized immigrant and refugee communities, women with varying ability statuses, a group that we often don't talk about their care and labor and delivery, certainly women who identify in the LGBTQI community. So I share that just to do a heads up. Now, this is a slide where I'm going to come off of screen share again, and I'd like as a group, as fast as we can, what would be signs or possible responses from patients that you see on L&D that your radar goes up? There's a red flag that goes up that you're wondering if they have a trauma history. So, would you just we're just going to do this as a group for a minute. What would be some of the cues that or signs that you got a red flag? Maybe I can look at the chart to see if anybody's screened, or maybe it's time for myself or someone on the team to screen. What comes to mind? Crying during an exam, with legs with exam, okay? Bracing, not really being reluctant to allow you to exam. What else? Good.
Feel free to come off mute as well.
Yes,
Chat
please.
is always there for you too.
When you think about the last patient you saw with L&D, where you were highly suspicious that there was a trauma history or current trauma, what were you seeing? What were you hearing?
We had one patient who was extremely fearful when she was pushing. She was very afraid to push. She was yelling, "Help me, help me." It was pretty evident that something had been going on with her. Absolutely.
That's a very unusual in the broad number of hundreds of patients you deliver in the course of a year. So very different, good, definitely a red flag. Reluctant to push, saying something that's a little different. Someone mentioned, someone else answers most or all questions. That's a good one. Physical scars. Yep. Someone else said something, crying, withdrawing. Yep. Those are really good examples, and more will come out today. as we talk. So give me a second. Thank you for that. All right. So again, someone mentioned physical scars, and in fact, there are many patients who present with physical conditions, both in the short term and in the long term, such as scars, traumatic brain injury, not being able to process information from prior head trauma, a whole host of physical conditions that may have a slightly, for which there is a slightly increased risk of trauma. Certainly increased rates of anxiety disorders, especially PTSD, depression, and especially recurrent depression, substance use, and a subset of women with personality disorders. We also see women with marked poor self-esteem, diminished sexual health, and definitely trust and relationship concerns, which we're going to talk about quite a bit today, because that's just a place where you're really going to want to work on labor and delivery to build trust and build communication. I think most of you are quite familiar with the neurobiological impact of maternal trauma on fetal, neonatal, and child development. And of course that women with adverse events are far more likely to have changes in their diminished self-care and increased health and mental health and substance use utilization. A subset of women with histories of trauma have avoided their general GYN and OB care, which may in fact complicate their labor and delivery experience. And as you mentioned, marked distress during OB and L&D procedures, which I'm going to talk about in a moment. So I just, because you're more focused on substance abuse discussion in this collaborative training, I wanted to pull some stats for you. 80% of women seeking treatment for substance use have a history of sexual assault, physical assault, or both. That's an exceptionally high statistic. It's not often we see something that high. And in fact, about 30 to 60% may have PTSD symptoms or meet criteria for post-traumatic stress disorder. The majority of women who have both PTSD and substance abuse were victims of childhood sexual abuse and are vulnerable to repeated trauma in adulthood. So we see so many women who have had adverse childhood events, such as childhood sexual abuse, and then interpersonal or other types of violence as an adult. And they're far more likely to have other psychiatric issues and interpersonal challenges. So what am I going to do with you today very quickly in about the next 30 minutes, because we want to have time for a conversation. I want to quickly talk about procedures in L&D, which may be distressing or triggering. We're going to talk about trauma-informed care, talk about some screening guidelines, and also some of what providers and your team might do when a woman is has a history of trauma on L&D. So this is actually one of my favorite topics, but we're not going to have a lot of time. But to be aware of L&D procedures that may be very difficult for a woman with any kind of trauma history. So not surprisingly, a pelvic and rectal exam or a breast exam, both in outpatient OB, and then certainly a rectal exam that might be necessary, that would be common in L&D. Pelvic ultrasound can be extremely difficult for a woman with trauma, including labor and delivery. And our colleague on the call just gave a perfect example of how that might have been triggering when she was asked to push. Injections and IVs can be extremely difficult depending on the type of abuse somebody has experienced, as can any sedating medicine, medication, or anesthesia. So why are these so difficult? Well, penetration with an instrument, a needle, an ultrasound, a finger for a vaginal or rectal exam, working on an episiotomy scar, any of these can be very activating and distressing for a woman who's experienced trauma. Pain can be quite triggering, whether it's a venipuncture, surgery, medications, any kind of labor and delivery or episiotomy can be triggering. Exposure. So by definition, most L&D settings have a lot of strangers and a lot of different individuals moving in over the course of several days, which can be very difficult, create a high degree of mistrust and an environment of vulnerability for someone with a history of trauma, and lack of control, which is very kind of one of the major examples of their experience when there's been trauma. Anesthesia, loss of bladder or bowel control that may happen during a delivery. Sometimes the need to be very still, putting an epidural in, having a strip on. So all of these, without kind of belaboring the point, can be very activating. And so you want to be thinking, when you know of a patient with a history of trauma, of talking with them before that happens. So what I'd like to do now is move into some very specific OB provider and team approaches that are really offered as a way to empower women with histories of trauma to improve their well-being. So what are some of the major components of trauma-informed care on L&D units? So first, it's for all of you to really get very skilled at recognizing the signs and symptoms of trauma in your patients and perhaps their families. And my guess as a group is that you're actually already very skilled at that. Being very clear about how and who and when you're going to screen for prior and current trauma. Changing your clinical approaches, your perspective and your approach to address the impact of trauma on women. How do you shift your provider and staff interactions and approaches on L&D when someone's experienced trauma? What is the clinical management protocol that you use? How do you work collaboratively with the entire team? From the person who greets the patient walking onto the floor to the environmental services staff, to anybody who has direct patient contact. And what are your resources for connecting patients with community trauma and recovery resources? So I want to share a slide for a second from ACOG with their definition of interpersonal violence. Interpersonal violence is a pattern of assaultive and coercive behavior that may include physical injury, psychological abuse, sexual assault, progressive isolation, stalking, deprivation, intimidation, and reproductive coercion. Interpersonal violence is a fundamental abuse of power and control. The reason I share that today is that abuse of power and control is one of the guiding principles in how to think about giving women a different experience in labor and delivery, and hopefully throughout their pregnancy. So one of our roles is to move patients from stigmatization of violence to normalization and validation that what they happened to them shouldn't have happened. From disempowerment and lack of control to empowerment. From a sense of victimization to a sense of resilience. In essence, that we have an opportunity to help women experience labor and delivery and the birth of their child as a part of their self that's resilient and empowered. From us moving from questioning to believing and validating patients' experience, to check our biases and assumptions at the door, and to be able to be present and empathetic. So these are some of the fundamental shifts in how we work with women. So what does this mean on labor and delivery? It means working to create this real sense of physical and psychological safety. It means building and maintaining trust, even when you're just working with a patient for a few short days, unless they're on the antepartum unit or transferred or have a longer stay. It means working with them to establish hope and healing and recovery. Finding ways to work with them collaboratively. So often we are doing to patients instead of working with. To figuring out subtle but very specific ways to help patients have more choice, to feel empowered, to communicate what is helpful to them, to build their choices and their resilience, and certainly to offer very gendered and culturally responsive care. So, what does all this mean? It means emphasizing the control that a patient has over her medical care, the his shouldn't have been there, her or their medical care, which is one of the foundations of trauma-informed approaches. We're trying to prevent re-traumatization by empowering survivors to be in control of their own bodies and their own experiences. And I'd be the first to say that's a tall order in L&D, but there's many ways in which we can do that. So we're going to have our first poll, and I'll tell you what it is, and then I think Katie's going to bring the first poll up. All women seen in our general OB practice are screened for current trauma. And then the next question, because I know some of you see patients in OB. Oh, you can do it while I'm on here. Okay.
Yeah, we will do it one at a time.
Right. All women seen in our OB practice are screened for current trauma. So whether you see patients or not in a general OB practice, even if you're just on L&D, do you know that the patient's been screened or?
Okay, we have some people voting still. I will end the poll in a second, but if you should be able to see a little poll pop up from Zoom. Okay, I will end the poll. Oh, we still have some votes coming in. Fun. And I'm gonna end it now. Okay, so here are the results.
So interesting, only about a third, let's call it a third. That's interesting and kind of concerning. So we'll talk about that in a minute. Okay. All right. You can close the poll and let's do the next one because the next one is specific to L&D.
Okay, here's the new one.
All women seen in our L&D unit are screened for current trauma.
Okay, we have votes coming in. Okay, I'm gonna end the poll and share the results.
Okay, so interesting. It's about the same, huh? That we're only at about a third. Okay, you can bring the poll down. Thanks, everybody. And I can't seem to advance my slides, so I'm going to stop sharing for a second. So hard that I don't get to see you. Give me a second. Okay, so only about a third of your practices are screening in outpatient OB or on L&D. So that's of concern. When you look at the ACOG clinical guidance on screening for interpersonal violence, and I would say this should be true for any kind of prior or current trauma, it's recommended to screen at the first prenatal visit, at least once per trimester, and at the postpartum checkup. Now, not surprisingly, I would insert that I think it's vital to screen on labor and delivery. So some guidelines about screening: you want to screen the patient in a private and safe setting when she is alone, no family, friends, or others around. If you need me to explain why, I'm happy to, but this should be screened and she should be screened in private. Please use professional interpreters and not someone associated with the patient. She may not be able to answer in a true way. At the beginning of the assessment, you want to kind of provide a larger framing statement that this is a routine, that we screen all women across the for trauma across the lifespan because it's so common in women's lives. It's not because you necessarily think or suspect interpersonal violence. And you certainly want to review the confidentiality of that discussion, especially if you live in a state law, in a state where the an OB or OB provider must disclose. So kind of incorporating it into routine screening can really be invaluable. Obviously, not surprisingly, ACOG recommends tight relationships with community resources for women with any kind of violence. And you want to keep materials handy. In Philly, I used to work with a whole group where we had these cards that could go on the under the sole of a shoe, and so that it was invisible, and to make sure you have materials that are readily available. Oftentimes women will not acknowledge abuse, but at least you've opened the door for the conversation coming up again. So again, when to screen and how to screen. Well, if you're in outpatient OB, first visit and or first prenatal visit and at least once per trimester, but on L&D to seriously consider a screening protocol for trauma as part of your routine evaluation, and certainly postpartum. So I'm not going to go into the national best practices with all the variation, but to say that lots of places do it differently. Intake forms, in some settings, the MA screens in others. In others, the labor and delivery or women and infant nursing staff screen, sometimes the OB provider per se or nurse midwife. I think the point is to have a clear pattern and protocol for how you're going to screen and ask direct questions. So what do you typically want to ask? When did trauma occur? What's the timing and duration of the trauma? You want to know if the perpetrator is still is related to the patient and still around, because you need to know whether the patient is still currently safe or is in contact with the perpetrator. So there was this article on trauma-informed care in OBGYN that said, well, you only discuss a patient's trauma history to the extent that it's necessary for the provision of care. I don't think that's right. I think that's a very narrow view of our role in discussing trauma histories. So I would add to that, discuss a patient's trauma history to the extent that it's vital for the provision and change of care and vital for the patient's physical and psychological well-being, as well as the health of the pregnancy, infant, and family. Since you all know the stats extremely well on the relationship between substance abuse, depression, anxiety, other psychiatric issues, and not only physical outcomes of the pregnancy per se, but the mom's well-being, the infant's well-being, and a family well-being. So I respectfully disagree with this particular article and would invite everyone to have a broader frame. It's also vital to ask about different types of trauma, not just childhood sexual abuse, since the statistics bear out that clearly a high percentage of women have experienced multiple types of trauma across their lifespan. When it's possible, and this is extremely hard in L&D, having kind of the same or close to the same OB provider and team group can really be helpful. That's tough with rotating shifts, but the extent to which you can assign similar providers can be extremely helpful. When talking with women, open arms, hands in front of you, face the patient. In our culture, we tend to predominantly have eye contact. There's obviously cultural nuances. You do not want to block the door. Your goal is to be very present with patients. And to routinely say, because abuse is so common, I ask all women about their trauma histories. And then you can go through a series of questions and we'll give you these. Were you touched in any way that made you uncomfortable? Do you have a history of childhood sexual abuse? Were you ever sexually assaulted or raped as a teen or as a young adult? In the past or now, are you in a relationship that's physically, emotionally, or financially abusive? Prior to coming to the United States, were you physically or sexually abused? So those are some examples of questions. So I want to talk a little bit about clinical strategies on labor and delivery. These are true for outpatient OB as well, to increase patients' control during exams and procedures. You first want to explain what the OB procedure is, and it might remind them of an earlier trauma. But your goal there is to separate whatever happened before, that this is about their adult health and well-being, and meant to be of help versus hurting. Now, historically, most providers don't ask permission to examine a patient. When we're delivering trauma-informed care, I mean, I think probably we can make the case where we should always be asking whether we should be touching a patient, but that's especially important when there's a history of trauma. When there's an opportunity to interview a patient in street clothes before putting a gown on, even in L&D, that might be great. That's a little tough, but sometimes can be really helpful. Obviously, draping patients well, being more mindful of needing to drape a patient. Who decides the pace of an exam? The patient. Obviously, that in L&D needs to shift if there's something's acute going on and there needs to be some stat procedures. But up to that point, if you can pace the exam with the patient, faster is not always better. I appreciate that there are multiple times in the course of your day where faster is better. So I don't want you to think I don't get that. But in the main, when there's an opportunity to slow down and pace the patient, that can be ideal. So here's our next poll. I always ask permission before starting the exam and ask it again if it's okay to proceed several times during the exam. So for those of you who are OBs and nurse midwives, could you answer this question? All right, and how the results look on that one?
We still have some votes coming in. We don't have as many people who participated in this one as in the last one, so I'm giving it a little bit of time.
Yeah, because it's not the whole group.
Right. Okay, I will end the poll.
Okay, that's great. Way to go, providers. Glad to see that we're reversed. It's about 60-40. So actually, there's a higher rate of asking about starting an exam. Very good. All right, let's see if I can go to my next slide. Great. So I kept this slide in. We're not going to, it's more really for outpatient OB, but I wanted to kind of talk about the continuum a little bit. But it's true in L&D as well. Asking about their prior experience. Have they obviously you're going to know if they've delivered before, but hey, how do they do with these exams? If you need to pace, you know, do you need to start with a history? Can you then do a pelvic exam? Trying to say, hey, what would you prefer? Again, to try to give some opportunity for choice and control. When you can have patients sit up, you want to be talking here and now. Not about prior stuff during any kind of exam or procedure. It's an opportunity to educate patients about her or their body, their pregnancy, labor and delivery, postpartum, not so much prior stuff. There are a subset of individuals who really would benefit from holding and seeing themselves in the mirror, others not so much. That's kind of interesting when you see the response to that invitation. Okay, so what are some red flags when you are on labor and delivery and a patient has a history of trauma? Hypervigilance, just completely scanning, questioning everything and everyone. Muscular and physiologic reactivity. Someone mentioned that, you know, their legs are like about to kick you across the football field or across L&D, that they're so braced. You want to make sure the patient is breathing or are they holding their breath, becoming very, you want to really watch that. Looking for, oops, I forgot to edit the prostate. I don't think you're seeing too many people with prostate and testicles on L&D. But if they're bracing vaginally or rectally, and you will know that from your skilled exam. So you want to be helping patients decrease that bracing before and during the exam. Do not let your MAs say, hey, you know, hold my hand, squeeze tight. Why? Because that creates physical bracing. You want patients to have low and slow breathing, diaphragmatic breathing. You're trying to help them quiet their autonomic nervous system, never mind that they're about to deliver. But still, you don't want things that increase that bracing. So looking for cues, patients not present seems extreme, looking out the window, looking behind, eyes kind of rolling back, the patient kind of communicating excessive need to be in control. You want to focus on here and now. You want to support the patient in being in control where she can. You want to engage patients in adult conversations, adult health and well-being, supporting her experience, positive experience around her body, especially if her experience of trauma was specific to physical or sexual abuse. Again, it's using an empowerment framework versus another violation and setting kind of small, realistic goals. I actually think many of you in L&D are really good about kind of helping women kind of get to that next step, those little small goals. So I think this was an easier one for you. But just saying, what can we do to make this experience more comfortable, less stressful, less distressing for you? Knowing that your patient knows herself better than anybody. Does the individual want to be alone or with a partner or friend? Do they need coaching? Hopefully these conversations have happened before L&D, but not always. I know I'm thrilled that we have some nurse leads on the administrative leads on the call today. Really making sure that you're introducing the team that might be working with the patient today so that there's not all of a sudden 10 people in the room. That's really disconcerting and unsettling for somebody who's got a lot of trust issues, which is really what this is about, building relationships and trust. So what about support persons on L&D? COVID aside, because that's just this has been a very complicated conversation, as you know. You're trying to support patients and having very supportive, mature individuals who focus on the patient, not their high maintenance family member or friend. You want to obviously rule out current interpersonal violence with a family member, the father of the baby, friend, partner. So just kind of figuring out like who is going to be there and making sure they're not actually the perpetrator. If there's a person involved during L&D, and obviously we've shifted now with COVID, helping that person position his or herself or they in a way that's not really watching, it's giving patient privacy if that's what's necessary. Obviously, if they of really kind of helping them turn towards the patient versus necessarily the vaginal delivery. So obviously use your judgment, but you may need to do some coaching and positioning of a chair, saying, how about you sit here and turn towards? So feeling free to support them in that. Okay, red flags, patients not present, looking away, hardly speaking, a childlike voice, someone already mentioned continuous crying, high levels of distress, trembling, very protective posturing. That's what that is, no, go away, won't let you examine. Somebody who's looking like they're having a flashback, become very short of breath. And I'm not talking about, breathing from the experience of pushing. This is like they're having a panic attack, and you will be able to tell the difference. Flat affect clearly would be a red flag. Doesn't always mean that they've had trauma, but it should be a red flag. Excessive anger, and certainly dissociation. So when you see those things, this is a harder conversation on L&D. We're not going to just say, hey, let's stop, a delivery. But there may be times when you're just like, let's just take a minute and pause and see if we can help quiet, using a very empathetic and positive tone of just being very present with patients. This may be a great time to bring in if your behavioral health providers or substance abuse providers, if you have them on site, or ask for a CL consultation liaison site. Obviously, as part of your pathways, you're going to refer for ongoing behavioral health care. You want to really be connecting with the patient before they go home about next steps. You did really, really well. I am concerned though, you just finished such an amazing recovery program. I know you're thrilled with the baby. Let's talk about it. This is stressful. Let's have a conversation about what you need to support your sobriety or whatever the example is. And really a great follow-up. Okay, so when do you refer for behavioral health as part of your team? What time is it? Okay, we're right on schedule. When patients ask for referral, clearly when they're avoiding procedures, this would be more an outpatient OB. Persistent bracing, a lot of reactivity with you on the floor. When there's obvious drug use, clear withdrawal when they came in, when there's been a recent relapse, or you really think that they might be at risk for relapse. Great time to refer to behavioral health and substance abuse providers. clearly when you have screened for depression, anxiety, PTSD, and or you're very clear that they're very overwhelmed without good coping resources, this is a good time to maximize resources. Questions about relationships, kind of clear family dynamics or dynamics with the father of the baby that's raising red flags. Single and underserved women definitely are at increased risk. And so these are good times to refer. When you're concerned about adherence to postpartum care, good time to refer as well. Okay, our last poll question. Does your labor and delivery team use trauma-informed care with patients who have a history of or current trauma on L&D? Katie, back to you. How's it look?
Oh, we still have a couple votes coming in. I'll give it a second. Okay. There we go.
Okay, so we're that 40-60 split, not so much. A good number of L&D teams, but not quite where we'd like that. Okay, so blasted. Why do I lose my slides when you do that? Just have a couple more slides and then we're going to go to discussion and case here. So part of your work is to recognize the signs and symptoms of trauma in your female patients on labor and delivery, to also really think about through what it means to work collaboratively in a way that's empowering to patients. So part of this discussion means ensuring that your entire team, all of your staff, irrespective of their roles, receive training about trauma-informed care, and that training is pretty regularly offered, since we know that our teams change so often. Residents come and go, nurses come and go, providers come and go, you name it. So don't just do this once every 10 years. It's important to think about your protocol for screening for trauma. Who, what, when, and where. You don't want 10 people asking the same questions about trauma. So when does it make the most sense, and whom? You're experts in care plans for patients during and postpartum. This issue needs to be part of that care plan. And so team encounters are really ultimately opportunities for women to feel more in control, to empower them, to improve their self-care, to support their recovery, to protect infants and children, and to really promote resilience of not only patients, but children and families. So I want to leave you with a series of questions to think about for your L&D teams. What would it take as an entire service to implement trauma-informed care policies and procedures? Do you need technical assistance to do that? Could this be a wonderful quality of project? What is your protocol for team communication around patients' trauma history and how you might adjust your approach to their care? To the extent that you can impact scheduling, can you, for example, have for an induction or a scheduled C, have patients, have providers on the team that the patient might have already met in the outpatient setting? Again, where you're building on those relationships and trust. That's really tough in L&D, but boy, when you can do it, it can really make a difference. I'm about to reach out to Ian about a patient who had a really difficult first delivery, and see if we can't do that together a little bit. That's just an example of good collaborative, trying to do some team building to make this patient's experience better. And that happens not infrequently. So a meet and greet can be super helpful. Can you change the workflow where maybe a patient really needs a female provider, or conversely needs a male OB to deliver, or midwife? Are there ways to flag in the chart so that, you know, trainees on labor and delivery aren't screening for trauma over and over again? What about updated consents in the health system? There may be perpetrators who under no circumstance should have access to records. So are those updated on L&D? Again, educating your team, but that's not just your clinical providers, that's your administrative lead, your PARs, your MAs, your security. Making sure you're considering behavioral health providers as part of your L&D team. What do you do to build and sustain relationships with trauma providers in the community? What's the protocol for follow-up? If a patient had an exceptionally difficult triggering delivery, what's going to happen and how are you going to communicate with the outpatient provider who's going to do their first postpartum visit? And what is the culture of your L&D unit for support, for trust and empowerment so that L&D becomes a safe zone and an empowerment zone? So how many of you would say this? I was wrong. This is our last poll question. On L&D, how many of you would say you use trauma-informed care approaches? So we'll let you do that one. Whoops.
I think that's the one that we just
Same
did.
question. Never mind. We just did that.
Yeah.
Okay.
I like double checked, but yeah.
No. It's the same question. I must have not deleted it. So what strategies do you use with patients who have experienced trauma as providers? What strategies are your team using? What's working? What's not working? Where are there gaps in your trauma-informed protocol? And how do you evaluate the impact of trauma-informed care on your patients, on your team, and on your health system? All of this, when we all work together, we're able to deliver trauma-informed care to women and to families. We're able to facilitate recovery, relapse prevention. We're able to facilitate resilience and empowerment and a sense in health and well-being. And I think you'll all agree that has dramatic impact on women's well-being, on families' well-being, and on our communities. So I hope that was helpful. Oh, I'm 4 minutes off. What we'd like to do is have an open discussion and maybe talk about Miss R. She's a 23-year-old single female who was admitted to L&D to deliver her first baby. When you examined her, she was highly agitated, tearful, and short of breath with considerable physical bracing. She's about 10 months out of a recovery program. She has a prior history of serious sexual assault and physical assault as an older teenager. I'm going to take us off of screen share, and I hope that as many of you as possible could come on video, and we'll have a final discussion here for a few minutes. And I sure hope that that was a helpful overview. Okay, let's see if you can all join us on screen. That would be great. Okay, thoughts? How would you approach Miss R? Now she's sobbing, so you're going to do something. She really won't let you really get through an exam that she's going to be delivering. She's here for an induction.
Can you bring up that slide one more time?
I can.
My husband just started with a weed whacker, so I missed part of it.
23-year-old, single, didn't show up with anybody, having her first baby, 10 months out of recovery, highly agitated and bracing during an exam, has a history of being gang raped. So now you're examining her and she's sobbing and she's clearly bracing. What would you do? Would you just plow ahead? I don't think so.
No, I'd stop the exam and I'd probably pull up a chair and sit down next to her and just let her have a few minutes to calm down, and then I would probably just start more with just visiting, maybe pause and talk more about just the induction and why we have to do some things, and then let her help decide her plan of care. How important is that initial exam? If she just had one in the office, I might not even need to do one, and I could just proceed with the induction. But I would try to make her as much a part of the plan as possible.
Awesome. Well, I heard lots of different steps in there. One is turning towards being present, turning the control over to her, like what would she be okay with next? What else? What, anybody disagree with our colleague or have some additional steps? That sounded really like a really nice way to go, a helpful way to go. Don't all talk at once.
She is there by herself. So, I mean, you do have the opportunity to screen for current trauma support systems, things like that, opening the conversation, allowing her to maybe offer up some information about those topics if possible.
So it's a good, you've got some privacy to screen and ask her, okay, what's going on? I would actually also say, you seem really unsettled. I'm really sorry. Can you talk to me about what you're thinking or feeling and see what she'll say? If she's very quiet, you might start to ask her a few more questions. I like the recommendation for Michelle to pace her though. Just partly being present with her and saying, I'm sorry. And you can also say, is someone hurting you? And then ask more specific questions. What is she thinking about? Mobilizing support would be really important. What else?
I also think that once she's calmed, I would also try and see if she can share with me some things that would help her make her feel more comfortable, whether it's positioning or having someone else present or things like that.
Absolutely. Perfect. Like, would she like to sit up? Would it be easier? Would she prefer to, keep her shirt on up top? What has helped her in the past calm down? This is a patient who's just had a really good experience in recovery and is in fact abstinent. What did she learn that she can bring to that experience, from that experience to labor and delivery? And there'd be a lot. Chances are they taught her some breathing, some mindfulness, some positive statements, shifting her. This is my case example was meant to say this is something she's excited about becoming a mom. So kind of connecting her with those feelings of how does she feel about the baby coming soon? Is she excited to meet the baby and parent? Maybe excited to give this baby a different experience than she had. So those are good questions and helpful to reshift to now we have a 19-year-old who can make some good choices and be empowered about becoming a mom, as hard as it is. Any other last comments? And then I think we'll have a general discussion about what we've talked about and close up shop. Was this helpful at all? Too basic, too much, too little? Each of those slides has so many nuances. Michelle, you've got your fingers up, and Sherry, you're shaking your head. What's made it helpful or not so much?
I just think it's really impactful for those of us in this area, well, in all areas of care, to hear, one, the statistics. I think in my long time doing labor and delivery, and I had mental health before that, I see providers maybe get frustrated or dismiss things because they don't have that education. And so much of it goes together. So I think sharing statistics, case studies are really great. And then actually just having those of us that do it slow down and really look at that process. How could we serve this patient better?
I'm glad that that's the impact of the discussion. I think that's all terrific. And some of you may want to take a deeper dive on your team approaches and policies and procedures, and you're welcome to reach out to Jamie or Katie or directly to myself. And because I'd love to see many of the base rate of screening for trauma and having trauma-informed care was not nearly where we'd like it. An obvious step would be to sort of do the next step of this conversation of what would those policies and procedures look like? Siri, you had your hand up. Helpful, not so much?
I think it's really good to for us as providers to just be able to share with other people. I think sometimes it's good to go over kind of the overall picture so that we can talk with other providers about it as well when we're in our position. So I think that it's great to hear.
Good. Any other comments? And Sarah's saying that with a more elaborate behavioral health support team. So I'm glad that was still helpful. Other comments?
I really like the suggestion of regular staff education. I just did some sexual assault nurse examiner training, and so sometimes my mind is already there, but when I mention, history of abuse or whatever to my staff members, they're really, like, what made you go there? So I think it's so important for it to be on everybody's radar. And the statistics are high, but there's so much that's not even reported. They're probably higher than that.
Yeah. Well, thank you for the opportunity to work with you. I want to thank CPCQC for your focus on not only substance abuse, but the relationship between substance abuse and, sadly, inordinately high rates of trauma. And we would ask you to give some concrete feedback so that we can adjust this curriculum as needed. Obviously, it was meant to be an overview today. I'm sure some of you were bored and some of you it's new. You can let Jamie and Katie know if there's a desire to do a deeper dive on any particular topic. Thank you all for what you do. Be well, be safe. Thank you for your commitment to women's health. Take care.
Thank you all
Helen.
so much for being here, and thank you so much, Helen. If everyone could fill out that post-call evaluation poll that's popped up, that's super helpful for us to get your feedback. Of course, just like Dr. Kuhn said, if there's anything you wanted a deeper dive on or have further questions on, feel free to email us. Any feedback at all, we're always excited to receive. So we really thank you, and we'll sit tight for a few minutes so people can keep filling out those polls. And yeah, thank you so much.
Thanks, everyone.